I hope everyone can hear me well and can see my screen. Uh, Without further ado, let's start with the presentation for my side. Okay, so what I'm going to talk about is the benefits of early diagnosis and treatment of multiple sclerosis, and how we can deal our patients or early on in their disease process, which is actually very important. And I think the general neurologist need to have this information to convince their patients about the treatment modalities available and how much helpful it could be in the start of the disease. Um, this lecture is sponsored by Roche. I have to give my disclosure. So let's talk about some statistics. Dr. Suhaib has already given some information or the baseline information about multiple sclerosis. So it's a disease of white and gray matter. So it was an early notion that it mainly involves the white matter. But what we have learned over the past decade that it pretty much involves the gray matter, and the gray matter involvement actually starts earlier than the symptomatic disease, or probably actually earlier than the white matter involvement, which is a very uh, advancement in the diagnosis and the treatment of the disease. And it has many implications from the clinical perspective. Approximately 1/3 of the radiologically isolated multiple sclerosis patients develop frank multiple sclerosis in the next 5 years. So even we suspect, like Dr. Suhaib mentioned, there's a radiological criteria, there's a clinical criteria, but if it's a radiologically isolated MS, which means there are just radiological changes, but no clinical changes yet, still these patients tend to develop MS in next 5 years. There's no consensus in terms of treatment yet, but Dr. Wasim will talk more with respect to that. There is a notion called no evidence of disease activity, which is kind of the aim we all, as neurologists and MS specialists, like to achieve. But there is a further depth to that. So what does this exactly mean is that there is no clinical or like a relapse or attack, or no radiological evidence of MS activity or inflammatory activity or attack over a period of almost 1 year. So this is the goal we all try to achieve, not 1 year, even longer, but this is the whole point of starting the treatment on these patients. So as Dr. Suhaib rightly mentioned, CT scan, open or standing MRI, low magnet MRIs are actually useless, because these MRIs don't show us all the changes what we like to see, or the extent of the disease, and especially if it's an early disease, or if we are looking for changes in the spinal cord, using a low magnet MRI will not be very helpful. And it does have a lot of economic and psychological burden. So it takes a really refined approach to the patient when you talk to them about the diagnosis, and when you try to convince them about what should be done next in terms of the treatment. So the disease course has been broken down, and it has been continuously revolutionizing, changing over the period of time. So now there are different phases of the disease, which is kind of new. And there is active or inactive status given to each phase. So there is a high risk phase, which is the early on phase when the patient has risk factors. Then there's a relapsing remitting phase, which most of the neurologists we know about is the relapsing remitting type of multiple sclerosis. Then there is a progressive phase when there is no relapses and it's just a progressive deterioration or accumulation of disability. And all these phases can be divided into active or inactive status. But more importantly, what we need to realize is once a patient is in the progressive phase, there is no going back. That is part one. Part two, almost 80% of the patients with multiple sclerosis at some point in time develop progressive phase. So we need to give this information at the right time to our patients, not to scare them, but to educate them that the treatment early on can actually delay the progressive phase of the disease and prolong the time when they're going to be having disability. And it also depends on with or without axonal injury. So there are some very good papers with respect to the spec which Dr. Suhaib has also mentioned, there is something called inflammation followed by neurodegeneration. By common understanding, if there is a damage and if the extent of damage is not too much, then we're going to heal or we're going to recover. But if the extent of damage is big or there is no treatment started, then there's going to be a permanent injury, and that injury not going to heal. There's just going to be a scar. So there is no returning back from that point on. It is further divided in a way. So this is the old way compared to the high-risk phase and the relapsing, remitting, and progressive phase. So what we knew before was the progressive phase with primary progressive phase, where the disease right from the outset is primary progressive, or it is initially relapsing and remitting, and then it changes into secondary progressive disease, which I have mentioned at some point. Some patients, almost 80% of them, develop progressive disease. And then there is a relapsing remitting, we already discussed. So the other two new varieties are clinically isolated and radiologically isolated. The radiologically isolated I have already mentioned. But in terms of the clinically isolated disease, it's just a patient had a clinical symptom or attack, but there is no radiological correlate. Well, if not a good quality MRI is used, you can tend to miss it, or if it's not the thin cuts. But if there is no other parameter, then we're going to call it clinically isolated disease. Knowing these phases or different stages of the disease is very important, because it will guide you about starting the treatment, when is the right time to start the treatment, and patient is mentally prepared in that period of time. Now, coming to the predicted disability in multiple sclerosis. So the patient, the most important factor which has been noticed is the age. So if age is more than 45 years or more, they tend to develop the progressive MS early on, and also the disability gonna be more in these patients. So age is one of the most important parameter which guides us about the predicted disability. The second biggest parameter is about the relapses. If the number of relapses are 6 or more in a period of 1 year, they tend to develop more disability and more quickly. So we need to really take active measures to convince the patient to start the treatment early on. The other predictors of progressive multiple sclerosis are male gender, obesity, smoking, low vitamin D, and spinal cord lesion. And if you notice through the list, actually almost 3 of them are modifiable. We cannot change the gender. If a patient already has a spinal cord lesion, we cannot do much about that except for treating acutely. But obesity, smoking, and low vitamin D are the factors which we need to talk to our patients and guide them, because it will help improving the disability of these patients in a long term. The extended disability scoring scale or status has already been discussed. So there is a functional scale to that. And when it gets more than 3.5, it has been noticed in studies that 50% of these patients are not actually productive or working. The biggest reason for them is not the disability, but actually it's the other features of multiple sclerosis, talking about fatigue. It could be not feeling good, feeling low, or depression. So there are other psychological or cognitive symptoms which make these patients not active member of the society, which is actually very important. More than 50% of the patients with relapsing remitting multiple sclerosis develop steady deterioration after 10 to 15 years. And that's where I'll say the phase is where we can intervene, the phase earlier than those 10, 15 years. Because if once the patients get into the progressive phase, then we are not able to stop it. It's just gonna steadily going downhill, whatever you do. And axonal damage, as I already discussed, is the core reason for having permanent neurological dysfunction in these patients. So this is a very beautiful graph which I got from this article mentioned at the bottom. So what they tried to show in this is in their patient population, once the patient hits EDSS score of 3, after that, because before that is or up to 3 is mild disability, but 3 and more is moderate disability. So once a patient gets into the phase of moderate disability, it's just a steady decline. If you look through these lines, it's kind of steadily going up. There is no change whatever you do. But if you look at the first phase, in this, if you notice this, we can delay this phase up to like 22 years. It can be like early on in first year. So this is where we need to intervene on these patients. And this is what we need to guide our patients about the treatment. So there's a treatment window of opportunity, which is the phase 1, where we have to intervene and we have to guide our patients and start the appropriate treatment. Second part is the personalized treatment, because if a patient has early on severe disease, we need to decide a treatment which is actually strong enough. So there is a lot of studies going on, which I'm going to talk about a little bit, that early aggressive treatment is more helpful because naturally it comes with more side effect, or starting with some moderate efficacy medication with low side effect profile would be more helpful. So there is a lot of studies going on, and I'm going to talk about that. But the treatment for multiple sclerosis has to be individualized, which is very important because every patient is different. Their trajectory needs to be measured and seeing how they are progressing, and we need to adjust the treatment accordingly. We need to have a proactive approach. Again, every physician by personality is different, but I think proactive approach is something which is getting more appreciation, and with the reason that the patients are noticing long-term less disability. But again, studies are underway with respect to that. The other possible approach is watchful waiting, especially when we talk about clinically isolated syndrome, radiologically isolated syndrome. I recently had a patient who herself is a doctor, and she has one lesion which is consistent and related to her deficit, what she has. It's a sensory lesion. So what I'm doing right now is to talk to the family, letting them know what I'm thinking. But once this patient gonna have a second attack, the McDonald's criteria will be fulfilled and we will be in a good shape to start a treatment. But if there is a motor deficit, if there are more than one lesion, looking for other areas, especially in the spinal cord, we find one or two more lesions, I think we should start the treatment early on in this particular scenario. So there are two prongs or two forks, two arms to the treatment of MS. So there is immunomodulation and then there is immunoprotection. Now talking about immunomodulation, these are the most of the treatments what are being used in the market right now, and Dr. Wasim will talk about those. And then there is immunoprotection. So immunoprotection means either we build up our reserves early on, which is through exercise, healthy lifestyle, adjusting our vitamin D levels, controlling obesity. So these are the ones we can work on before we get into a high risk group, or if we are in the high risk group, to delay the disease. The other immunoprotection techniques I'm going to talk about, because there are some off-label therapies. Dr. Wasim will talk more about all the treatments of modalities available, but I'll talk a little bit with respect to immunoprotection. But there are limitations to early treatment. As we all understand, the most important question what we come across is the cost. We all know that because most of the MS treatments available in the market are expensive. There are a lot of side effects, and the treatment of those side effects cost even more. Second is with respect to the limited efficacy, especially when a patient lands into multiple sclerosis. But I think the window of opportunity is not in progressive, but in the early phase of the disease when we can do something for our patients. But once a patient gets into progressive multiple sclerosis phase, it's really hard to control the disease because they're gonna have progressive disability. We may be able to slow it down to some extent, but we may not be able to stop it. So there was this very beautiful article where a group of MS specialists, they got together and they put down some recommendations based on their experience and the evidence available. So what they come up with is a progressive brain atrophy in multiple sclerosis actually comes in the pre-symptomatic phase of multiple sclerosis. So even before the disease is clinically diagnosed, patients tend to have early cognitive changes, brain atrophy, even if spinal cord atrophy can be seen in these patients, which is very important because it also gives us the idea that they're probably going to have progressive disease and we need to treat them more aggressively early on. There is some repair potential through natural healing as we are young, and it has been noticed that especially in the age below 40, especially below 27 is kind of the cutoff number they have come up, that if a patient is below 27 years of age, their repair potential is actually good. So even there is a damage, as we discussed, there is a potential to heal to some extent, but after the age of 45, that healing potential is gone. That's why these patients after the age of 45 tend to progress more rapidly, because even small attack they will not heal well. The other important finding which has been noticed is that the younger the patient is, there are chances of having more changes or more gadolinium enhancing lesions in the brain, which we tend to see less and less as the age progresses, because the immune response probably by the brain is not that boosted after the age of 45. Again, the cognitive disability is a big thing, which was previously ignored to some extent. And it is actually more than the physical disability, and it kicks in even before the actual clinical disease starts. So the next line just says that the 5-10 years before the actual diagnosis, the cognitive decline can be observed in these patients. Again, there is some noticeable changes noticed in terms of the improved mortality with treatment. So if we start the treatment early on, there are less chances of having blood-brain barrier disruption, and it has been noticed that these patients have improved mortality long-term. And EDSS score is also noticed to be lower in early treatment group, which also are kind of a standard criteria to assess the progression of the disease. So all these point us toward early treatment of multiple sclerosis patients. The disease duration is a key factor in the impact of disease-modifying therapy, which was kind of the consensus statement from this meeting. Another important finding was that the long nerve fiber tracts, talking about the nerve fibers supplying the face, or the nerve fibers supplying the bladder or the lower extremity, longer the nerve fibers are, there are chances of more damage in multiple places, and not all those places may heal. So the patients tend to develop more difficulty in longer fibers, like talking about difficulty with the micturition or with the walking disability kicks in early on compared to the small tract fibers. Vascular risk factors pose additional damage to the brain, especially patients having cardiac disease, diabetes, or other vascular risk factors. They tend to have poor mortality, and also they tend to have more damage to the brain. But more importantly, if a patient is in the progressive disease or in the late part of the disease, the cost of treatment goes 5 times higher. So even we are not able to control it well, whatever we do, the cost is even more. So we need to assure this part, that we need to convince our patients that if we want to cut the cost and want to have them in the early phase of the disease longer, we have to start the treatment early on. So this was a graph where they kind of see the progression on treatment from first attack and from 5 years later on. And what they come up with, that if we start the treatment early on, we can delay the progressive phase by decades, which is actually very important. So there are some ongoing trials. There is one going on in Johns Hopkins. It's a Treat MS trial. And there is one going on in Cleveland Clinic with collaboration. It's the Deliver MS trial. The results for these trials gonna come up in the late 2022 or 23, and they are addressing the same question about early treatment and the aggressive treatment, how much that gonna change the EDSS or the progression of the disease. But we will have the final statement by these trials hopefully soon. The projects for the future are, from my perspective, that we should try to observe these patients clinically and try to have the time between initial symptoms and diagnosis, because it's a big thing. There has been a lot of studies in other countries, but I didn't come across much with respect to the how much time it takes over here if a patient develops a symptom and when they are actually diagnosed with multiple sclerosis, because it takes a good period of time, even in advanced countries. But I believe we should have our own data. The percentage of patients receiving treatment, because I have close to 10 patients, but so far I'll say whom I talked to about the treatment cost, they were backed off, and there were very few patients who actually stepped up to get the treatment for multiple sclerosis. Incidence and progression of the disease is different for each subtype of MS, but we need to look into the data based on our geographical distribution. So I think Roche or some other companies, with the help of the doctors or providers, should look into this, and it will help devising more studies in this geographical location in future. There are different care models in different countries. I'm not going to go into the detail, but we can have our own care model, and we should see how much it helps our patients in terms of their patient satisfaction and their quality of life assessment. So the summary for my talk today is that MS, as Dr. Suhaib has also mentioned, is a very heterogeneous and unpredictable disease. There has to be a lot of workup involved to really diagnose a patient properly and to really come to the point that this patient is a candidate for treatment. And with treatment, there is less cumulative disability. So first we need to confirm it, and then we need to convince them to start the treatment early on. There is no cure available. There are some off-patent therapies like statins. There is complications of treatment like progressive multifocal leukoencephalopathies and malignancies involved with the treatment. We need to talk to our patients early on in the disease, so they will be observing for that. And there are remyelination strategies talking about the healthy lifestyle, correcting vitamin D. I also suggest to my patients, it's a very common statement because many neurological disorders are not treatable, or it's just a lifelong disease they're going to have. So what I tell my patients is, see, from Islamic prescriptions and Islamic teachings, we all know that honey has all kind of shifa to diseases. So I always recommend my patients to use honey in some way they like to. There's no data on it, but I personally feel that exercise, healthy lifestyle, and all these alternative treatments are there to help our patients in long term. Thank you very much. But with the bottom line, early effective treatment and long-term follow-up is the key to have more data and to guide our patients even better.